Thank you for inviting me to participate in this meeting. I've had a chance to participate in a few of these meetings, and they've always been very positive experiences, getting to hear multiple different perspectives, and this year with the international perspective. As Rashmi said, I'm an adult and pediatric rheumatologist at the NIH in Bethesda, Maryland, where I run a clinical research and translational research program studying systemic JIA and adult onset Stills disease together. The panel discussion that we're going to have now is entitled Bridging the Gap Between SJIA and Stills Disease. Is it time to view them together? And our discussion today is going to include a panel of international experts with a pediatric rheumatologist, several adult rheumatologists, an adult systemic JIA patient, and me, a combined med-peds rheumatologist. The goal of the session is to discuss the relationship between SJIA and adult Stills disease, touching on similarities and differences, shared pathophysiology, clinical similarities and differences, and transition of care from childhood to adult infrastructures, and trying to tease out whether and how to pursue opportunities for unified research in systemic JIA and adult Stills disease. Just to briefly introduce our panel, first we have Dr. Bella Mehta, who's an adult rheumatologist and clinical researcher and assistant professor at the Hospital for Special Surgery in New York. She has a clinical and research interest in adult onset Stills disease. Second, we have Dr. Alexander Leonard, who's an adult rheumatologist, clinical researcher, and an associate professor at the University of Iowa. And he has both clinical and research interests in the diagnosis, management, and investigation of adult onset Stills disease. Next, we have Dr. Helen Levis, who's a clinical consultant in immunology and an associate professor at the University Medical Center Utrecht in the Netherlands, where her research focuses on autoinflammatory and primary immunodeficiency diseases. She works closely with pediatric rheumatologists at her medical center, and she's led a Delphi consensus process for the treatment of adult onset Stills disease. Next, we have Sebastian Bostert, who is a pediatric rheumatologist and associate professor at the University Medical Center Utrecht, where he leads both clinical and translational efforts to investigate systemic JIA, and frankly needs no introduction with this audience. And finally, we have Nicole Dalton, who is an adult systemic JIA patient. She was diagnosed with systemic JIA at age 12 in the pre-biologic era, and she's experienced a severe treatment refractory course of her systemic JIA with a number of different problems that she's directly faced through the course of attempting to transition from pediatric to adult rheumatology care. So she has a very valuable perspective to add to our conversation today as well. Perhaps I didn't introduce you guys adequately. If you have a sentence or two you'd like to say to the group about yourself, why don't we go ahead in the order that I introduced you. So Bella.
Hi. So I think, Mike, you actually summarized it pretty well. I'm from New York, and I'm an adult rheumatologist. I mainly see adult onset Stills disease patients, and my research interests are basically to classify uh, Stills disease epidemiologically. Um, and I, I think this session is going to be pretty interesting, Mike.
Thank you. Alex?
Yeah, Mike, thanks for the intro. I don't have anything particular else to add. I just want to say that, Stills is very, very important to start thinking about more broadly in the adult community. And I learned greatly from my pediatric rheumatology colleagues to kind of raise awareness and get to the level that pediatric rheumatology is operating at. So thanks for the invite.
Thank you, Alex. Helen?
Thank you, Michael, for a very nice introduction. So in Holland, the care for adult patients with Stills disease is very differently organized than for pediatric patients with systemic JIA. And yeah, I think we really should consider how it's organized for children as an ideal, how we get care organized. Our care is scattered over a lot of different rheumatologists all over the country, with many physicians not seeing that many patients with Stills disease. And we did our best to try to get a consensus in a Delphi panel. And I think we did pretty well for how far we could target this problem. Thank you.
Thank you. Bas?
Yes, thanks for the invitation. I don't have any additions to what you said, but maybe just for a national scale in the Netherlands, we have 16 pediatric rheumatologists and about 400 adult rheumatologists. Probably adult onset Stills disease is even a little more rare than Still's disease. So of course there is a difference in the amount of patients that you can see as an individual physician or researcher.
That's a very good point. And Nikki, would you like to say something else?
Yeah, thank you for the introduction. The only thing I'll add is my initial pediatric rheumatologist at Hospital Special Surgery retired, so I can no longer see him. So the rheumatologists I see here, they don't even, on my chart, it's only listed that I have RA, and it's very clear that I don't just have RA. And I'm not sure if it's an insurance issue or an access to medication issue, but there's definitely a problem of bridging the gap. And I can't get seen by a pediatric rheumatologist in Los Angeles for obvious reasons.
Yeah, these are clear frustrations that many of our patients face. And you are in the group who was in the pre-biologic era, so you're left with a very big burden of this disease on your life, and need to find physicians who are understanding and insightful about what can be done for you and how to do it. And so hopefully we can talk about this a little bit more today. I guess in the end, one of the goals that we have is to try to outreach to our adult rheumatology colleagues who aren't expert as those on our panel, to try to spread the word about adult Still's disease, and perhaps try to centralize the care of children with systemic JIA who've become adults or adult Still's disease. So I have a list of questions and topics that I generally outlined for us to discuss today. The first general theme gets at the question about the comparison of systemic JIA and adult onset Still's disease to one another, and whether they're really the same entity. And so, I'm just going to go around the horn here and say, do you want to point out similarities and differences between systemic JIA and adult Still's disease, and whether you think that they're the same thing? And we can go in the same order that we've established for this first question. So Bella, what do you think?
So I guess back about 10 years ago, when I started with Still's disease patients, adult Still's disease patients, I would start treating them as if it's a different entity. And, the more and more I start seeing Still's disease patients, I mean, all the drugs that work for systemic JIA work for adult onset Still's disease. And the more you see the treatment responses, or the more you see them closely, I started seeing that these probably are the same sort of diseases, especially because systemic JIA patients, when they grow, when they transition from peds to adults, especially in US, you can see that they're different than RA patients, right? Like Nikki just mentioned. So just irrespective of the literature and the pathophysiology, just on clinical experience itself, the more you see it, you feel like they are the same.
Thank you. Alex?
Yeah, so I think there's definitely an underlying similarity based on the data that's out there from translational research. Again, kind of done in groups largely consistent of SJIA patients and then some AOSD patients. But, we know that molecularly and from a cytokine perspective level, there's similarities. And I do tend to think about them that way. And I echo what Bella's saying about the treatment approach. And I think some of the treatment approach, again, is biased because we just, as adults, we just have no clue how to treat it well unless we have an interest in it. And so we borrow a lot from the peds world to start thinking about the disease. I tend to see, some differences because my Still's patients tend to be more in the 60, 70, sometimes 80-year-old age group, and they present with some odd presentations that don't nicely fulfill, Yamaguchi or Fotrell criteria. And so they'll have, failure to thrive or a fever of unknown origin presentation that's really hard to pinpoint down just by criteria. And it's more through an elimination process, unfortunately, that we arrive at the diagnosis a lot of the times. And then there are certainly ones that look very similar clinically. The other thing to consider is kind of their comorbid comorbidities that adults have. And I take that into consideration both clinically, but then also from a research interest perspective. Is, you know, with kids, we might not worry as much about using IL-6 inhibitors and worrying about their cardiovascular risk. You know, in adults, we're dealing with a completely different population. I think that comorbidities play a big role also in management, but also in the type of presentations they may have and the severity, you know, meeting them the first time in the ICU versus meeting them in the clinic as a second or third referral.
That's a great point. And with respect to the comorbidities, it hasn't really been evaluated, although I'm sure that we'll find that there's an increased cardiovascular risk for this kind of broad exposure to inflammation that our patients see. And so once that's been clearly identified, then the question about cardiovascular risk of IL-6 blockade versus cardiovascular risk of inappropriately or inadequately treated inflammation becomes the balance. Helen and Bas, there was a set of evidence-based guidelines that I saw at the ACR meeting, and I was struck because there was percentages of votes for consensus among the group. And one of the things that there was 100% consensus, despite not a lot of evidence, was, are systemic JIA and adult Stills disease the same? And 100% of people said yes. Am I correct about this?
Yes, you're right.
Yes. So what is your perspective on this question, Helen?
Actually, I think I totally agree to Alex's perspective. So I see some, especially males, older of age, that have an atypical presentation are often very difficult to get into remission. And interestingly, you probably all have heard from the new disease VEXAS, which also comes from NIH, from David Beck. And I think probably some of the patients, especially of those, for instance, with also maybe MDS, like underlying disease, so bone marrow problems, they have genetic diseases that are acquired, so somatic mutations that cause this disease. And maybe there are a lot of other diseases that we're just not yet aware of those patients that are really difficult to get into remission. But I also have part of my patients that are adults that I think pretty much are similar to patients with systemic JIA, and they respond superbly if I start them on IL-1 treatment. So,
and I have a similar experience to that with kind of a bimodal or a double distribution within the adult Stills cohort. There's definitely a younger onset group that looks very similar to systemic JIA. And then there's an older, more refractory to treatment group. And in my mind, I almost move them out of the adult Stills group because I think that they have somatic mutations that may be driving the inflammation that we see. In our cohort, it's not VEXAS because we've looked for that. But the question is, can we identify somatic mutations? Obviously, the way to do that is to get a lot of people together, because you won't identify the specific somatic mutation in the giant landscape of somatic mosaicism unless you have many people to identify them lined up within a given gene. Bas, from the pediatric perspective, what do you feel about the differences between systemic JIA and adult Stills disease, i.e. the developing skeleton?
Yeah, so I think one has to realize that also systemic JIA is, of course, quite a heterogeneous phenotype. Or a group of diseases with some more or less general, more or less general phenotypes, I would say. And there's great overlap, I guess, and what I've read and what I've seen and experienced in discussions with the adult rheumatologists with adult onset Stills disease, there are some differences. So I think the inflammatory pathways tend to be quite the same, and also the responses to biological drugs are quite similar. But for example, in the differential diagnosis, of course, also in the elder age group is clearly different than in the younger age group. So I tend to think of it as an spectrum or a disease entity with slightly different features and presentations at the different age groups.
Nikki, your perspective on the relationship between systemic JIA and adult Stills disease is probably very different than ours, thinking about it from pathophysiology. there's the relationship to what you have compared to people who develop systemic arthritis as an adult. Do you have something to add about this for us?
Yes. Personally, my disease has not changed at all from when I was 12 to my age now. Still the rash when I flare, everything is refractory. I would say my ability to tolerate medications, the biologics, and even the JAKs. I had anaphylaxis to rituximab. I actually did really well on thalidomide. Dr. Lehman put me on that trial. But the comorbidities got increased when I got old, have increased as I've gotten older. And then I am a part of a few adult onset groups, and they, aside from the rash, they all sound the same. They have very similar symptoms, but with increased comorbidity. And the frustration I have as an adult is I feel, and I'm not speaking from a place of I know everything, but but I feel like the captain of my own ship, where I brought an Orencia trial to a rheumatologist in Los Angeles, or an Actemra trial, because they just don't know, and it's through no fault. It's a very rare disease, and then also the IL-6 having implications on my gut. So I just take no one's talking to one another. When I was younger, everybody spoke to the pediatric. Everybody in peds spoke to one another. As an adult, you're shipped out to all the different specialists, and that's challenging. It's a full-time job that I don't want to have. So I would like to see that change.
These are great points. I'm not sure about in Holland. In the United States, there's definitely kind of systematic differences between the way that pediatric specialty care runs and adult specialty care, because in many cases, in every case, pediatric subspecialty care is affiliated with an academic center where you're going to have the other specialists as well. And the communication is, automatic through the medical record, if not through telephone calls. Whereas within the adult community, many people are in private practice unaffiliated with an academic center. And so you can have a piecemeal aggregation of providers, and that communication is very challenging, especially as the various healthcare issues and compensation and paperwork just continue to become increasingly burdensome.
Can I chime in a little bit, Mike?
Please do.
So I totally echo Ms. Dalton's frustration. I mean, we know the system is fragmented, and, we're witnesses to that today. I'm not going to get political, but I think we need to kind of somehow raise this awareness nationally and internationally. And I think there are models and countries that work way better than ours, European countries, Scandinavian countries, you name it. I think our adult patients are suffering just like she's describing. And I think one of the things that should be priority as well is to look at this long-term quality of life effect and morbidity in our patients with Stills, because that's not very well captured. And I think even looking at, novel trials in promising things like getting canakinumab approved in the United States for Stills, some of these other parameters that are captured as part of patient-reported outcomes are just not, they're not well studied, they're not assessed well. Our patients are not part of that feedback, and so we don't have a good connected network in the United States. And I'll let our Dutch colleagues chime in, because I'm sure it works much better over there. But we don't have a good way of, patients like Ms. Dalton connecting when she leaves a center like New York, and then in LA finding another Stills specialist. And so that's something, we need to work on.
Or even having when it's a severe situation, having your GI specialist speak with your rheumatologist. When it comes to having part of your intestines removed, they should be talking to one another. and so to that, and maybe that should be my job, but it feels very heavy when I am trying to manage my entire life and the disease process. So it's, and quality of life, what you're saying, I have, what I was able to do with this disease when I was in my 20s versus now is very different. My quality of life is definitely diminished. And I think if I had access to biologics when I was younger, I would have a different outcome. Yeah, it's quite diminished.
And so maybe we should take advantage of this and segue into talking about transitions a little bit, because the transition of care from pediatric to adult subspecialty care is often stressful for children, for families, for providers. Systemic JIA patients often transfer on a delay to adult rheumatologists, and this happens for a variety of different reasons. And so just thinking about barriers and obstacles and successes for transition might be able to help us to both craft a transition plan for systemic arthritis patients in general, as well as to work to unify the pediatric and adult communities. And I see that Boss is moving right now, but I was going to ask Boss and Helen to talk to us a little bit about the successes that they've had integrating their practices for systemic arthritis in Holland.
Yeah, so Bas, shall I start? So our hospital has a record of paying a lot of attention to the transition age. So I think for the last 10, 15 years, there has been a program where adult rheumatologists see patients once or twice together to build on the relationship the patient has with his pediatric rheumatologist, and to at least make clear that interaction between the two specialists is still there. And I think at least in Holland, for patients with systemic JIA, this means that a lot of patients stay in tertiary care, and that care can be centered. And I'm pretty sure that there are still patients who have difficulties finding the right doctor, and that we definitely can improve a lot. But at least I think these efforts have been taken to try to take care of continuous care, which is high quality enough. And yeah, I agree. Of course, if patients grow older, they develop different problems, especially if you haven't had the opportunity to be treated with biologics early in the course to get induced disease remission quickly, which is of course very important. And we try to optimize this quality of transition of care by every few years, think of things we can optimize and programs we can increase, especially for young adults. We have some special programs where they also can see each other and discuss in groups what they face in life, which is difficult to find better options how to cope with having a chronic disease, for instance.
Boss, do those sorts of peer support groups begin in childhood during pediatric rheumatology care?
No, in Holland, or at least in Utrecht, we have really organized this in the transition process, and it's actually an initiative from the adult rheumatology, which I very much like. So I completely acknowledge that Holland is a very small country, so things are way easier to organize than in such a big country like the US, or let alone in South Africa or in Asia or South America, like we just heard in the first hour of this conference this morning. But I think even here it's sometimes challenging. These are of course severely affected children, which really you really get a strong bond between a patient and physician, of course, in the course of the years. And I feel it really an advantage to have this type of, like we call it, a warm transition, in which we together with the adult rheumatologists have a couple of visits to guide the transition process, which takes about 6 to 12 months, dependent on how severely ill, how active the disease at that time is. One of the things I would really think would further improve this transition is more flexibility. So now in the Netherlands, also because of insurance issues, we have to complete the transition process at the age of 19. This is a very difficult and challenging time for patients. Often young people trying to get independent from their parents. They switch education, switch cities for their education. There are lots of things that are new to them. It's quite a challenging time to also get used to a new doctor and a new hospital. So if there could be a flexible process in which you could be more flexible and see patients until that, let's say 25, maybe it's not always necessary, but then you can choose what is the right time for transition. Because I think the one really prerequisite for transition is that the disease is stable. You cannot transfer a patient in unstable disease to another doctor. That's not a good care.
And also using specialized nurses who are really of great help to patients. I think that's also something we try to do. And that helps a lot, since especially in adult care, I think we have to see so many patients. It's sometimes difficult to just get hold of your doctor when you really feel that you need to be contacting this doctor. And then it really helps if you have a specialized nurse who knows when to call to doctor to get extra help and provide together the best care possible for your patient.
True. I would also add that social work has helped us a lot during transitions. Um, sometimes the patients already know the social work, so there's one constant person, and then the rheumatologists from peds to adults switch. So our switches are usually, especially for sort of sicker patients, are helped with, the social worker really weighs into this.
Alex, from your perspective, are there specific obstacles or things you've identified that make better the transition process for systemic JIA patients into your clinic?
Well, we take the advantage of something that was brought up in the chat box, which is, the students who go off to college, being a large college town here, we kind of take advantage of making that leap a good time to switch over to the adult clinic. And I'm fortunate to work with excellent pediatric rheumatologists at our institution who know how to recognize Stills and SJIA early, and so reach out to us. And when the patients themselves are ready and they go through the step process, they have a checklist of things that once they're ready to transition, we're kind of made aware of and we accommodate for them. So, but then this is this is micro planning at an institutional level. And so we're fortunate that we can somewhat do that here, but there's many who just fall through the cracks, as it's outlined in the chat box as well.
So, Michael, can we wrap up now?
Yes, of course. I had wanted to discuss a little bit about the treatment and bring forward the proposition that we should begin to treat adult Stills disease using algorithms that have been defined in systemic JIA. I don't actually think there will be a whole lot of debate about that issue, so perhaps we can just pass it. The one question that I will ask is, do you have specific ideas about obstacles to allow us to study adult Stills disease, and how we can overcome those, perhaps by joining together with pediatric rheumatologists studying systemic JIA? If you have one, just go ahead and say it.
I guess if in the adult world, there's not a lot of focus on Stills disease. It's rare. Yes, centers like NIH do, but even big centers which have centers of excellence, Mayo or HSS, they don't have a separate autoinflammatory center of excellence, and that's why the focus hasn't been that. So the resources don't go in that way.